Now what is Coombs testing? So Coombs test are anti-globulin testing. In this, a special reagent is added to the patient blood sample, which is Coombs serum, which contain anti-human globulin that detect and adhere with two binding sites to the immune protein that mediate hemolysis, for example antibodies and or complement. If these proteins are coating the RBC surface when the serum is added, so anti-human globulin will cause multiple RBCs to adhere to each other in the process called agglutination. If no such protein are present, so anti-human globulin will not bind to anything. RBC agglutination is considered positive result, while absence of agglutination is considered as negative result. Now we will discuss what is direct Coombs testing, as we have two types, direct and indirect Coombs testing. Direct Coombs testing is a key test in the workup of hemolytic anemia. It detects antibody and complement protein on the surface of RBC, narrowing the differential of hemolysis. In this process, patient blood sample is purified so the only RBC remain. Coombs serum is added and anti-human globulin bind to the patient antibodies and are complement already present on the surface of RBC, leading to RBC agglutination. So RBC are purified and are mixed with Coombs serum. If the antibodies or complement are present, so agglutination will occur. Positive results so indicate that the patient RBC are coated with antibodies and are complement that are causing hemolysis. What are the etiologies? We have autoimmune hemolytic anemia like warm and cold. We have alloimmune hemolytic anemia like transfusion reaction and hemolytic disease of the newborn, and drug-induced autoimmune hemolytic anemia due to methyl dopa, penicillin, cephalosporin, and NSAIDs, immunotherapy, and chemotherapy. Negative results suggest non-antibody mediated immune hemolytic anemia. So we have positive result and negative result on the basis of which we can classify and narrow the differentials of anemia. The second type is indirect Coombs test. In this, detection of RBC antibody in the serum. So for example, in the patient receiving transfusion or patient with hemolytic disease of the fetus and newborn, or the pregnant women who are at risk of developing antibodies that cause hemolytic disease of the fetus and newborn. What are the indications of pre-transfusion? Patient with suspected transfusion reaction, newborn with signs of hemolysis, and screening for Rh negative mother to determine if anti-immunoglobulin is indicated. In this method, patient blood sample is purified so the only serum remain, and direct antiglobulin test only purified RBC were used, but here the serum is used. The patient serum is incubated with test RBC, which are normal RBCs. If there are anti-RBC antibody in the patient serum, they will bind to the test RBC. Then Coombs serum is added and anti-human globulin bind to the patient's antibodies, which are bound to the test RBC, leading to RBC agglutination. Positive results indicate the presence of freely circulating anti-RBC present in the patient's serum. They may be responsible for hemolytic disease of the fetus and newborn or transfusion reaction. What are the etiologies? So etiologies include RBC, early immunization and transfusion recipient or newborn, and maternal alloimmunization. If the result is negative, so it means that there is no detectable anti-RBC antibody in the patient's serum. What is the difference between the Coombs test, direct and indirect? So the direct Coombs test is used for the workup of hemolytic anemia, while indirect is used in transfusion medicine and in perinatal care. Direct Coombs test detect the antibodies on the surface of RBC, while indirect detect the antibodies in the serum. Coombs serum is added to the patient purified RBCs, while here it is added to the patient's purified serum. Anti-human globulin binds to antibodies and are complement, already coating the patient RBC, while here it binds to the patient antibodies which are bound to the test RBC. Here they bind to the patient RBC, while in indirect it binds to the test RBC, which can be coated with the complement or antibody if it is present in the patient serum. So remember it, the direct Coombs test detect antibodies that are directly attached to the RBC surface. The indirect or not direct Coombs test detect serum antibodies that are not bound to the RBC but detect the antibodies that are present in the patient's serum. Now investigation of the underlying cause, so we can do the HB electrophoresis. Abnormal HB pattern can be present in thalassemia, and flow cytometry, absence of CD55 and CD59 are on RBC surface are present in paroxysmal nocturnal hemoglobinuria. Detection of CD19, CD20 and CD23 light chain restriction kappa lambda are present in CLL. We can do gene analysis to detect the mutation in congenital hemolytic anemias, and bone marrow biopsy can be used. It's rarely used, but it is used. Or the indications are pancytopenia, presence of neural cells like blasts, and CBC in CBC peripheral smear. Pathologic findings are most common in malignancy that replace bone marrow, for example CLL. Here is the overview of the hemolytic anemia. So when you have signs of anemia and hemolysis like decreased heptoglobin, increased LDH, increased unconjugated bilirubin, increased retic count, and abnormal peripheral smear. So you can go further to narrow the differential. If you have signs of acute hemolysis or hemolytic disorder like hemodynamic instability, acute renal failure, HP less than 7, not responding to transfusion, and recently received transfusion, so you can consider thrombotic thrombocytopenia or hemolytic uremic syndrome, DIC, HELP, or transfusion reaction. So evaluate and treat urgently because these are considered as emergency. Further, if you have these instability signs, then you do the direct antiglobulin test. If it's positive, so it means this is immune mediated hemolysis. If it is negative, so it means that this is non-immune mediated hemolytic anemia. Now we have two types of immune mediated hemolytic anemia. One is autoimmune hemolytic anemia, and the other is alloimmune hemolytic anemia. Autoimmune hemolytic anemia, we have further classification. If it is positive for IgG, and if it is positive for C3d, so we can consider different causes on the basis of the results. If it is positive for IgG, so we can consider it as warm autoimmune hemolytic anemia, which is extravascular hemolysis. So blood film will show spherocytes. It can be idiopathic, and it can be due to lymphoproliferative disorders like CLL, Hodgkin lymphoma, autoimmune disorders, drug induced. So we have type 1, which is heptin mediated, type 2 is immune complex mediated, and type 3 is anti-RBC antibodies. So these are the examples: penicillin, quinine, methyl dopa, and in treatment, so first line treatment is prednisolone, second line is splenectomy in children, and rituximab. Further treat the underlying cause. If it's positive for C3d, so we can consider any of the following, like cold autoimmune hemolytic anemia, which is intravascular. Blood film will show agglutinations. It can be idiopathic. It can be due to lymphoproliferative disorder like CLL and Waldenström macroglobulinemia, and infection like EBV and mycoplasma. In mild cases, warm the patient. In moderate or severe cases, give rituximab and treat the underlying cause. Second type is autoimmune hemolytic anemia, so consider it if the presenting is newborn, or history of pregnancy, history of transfusion, or history of transplantation. If it's newborn, so consider it hemolytic disease of the newborn. The neonate will present with neonatal anemia, jaundice, and hepatosplenomegaly. If it's diagnosed prenatal, so intrauterine blood transfusion is given. If it's postnatal, so iron, RBC transfusion, phototherapy, and exchange transfusion are done. The second is recent transfusions. So we can classify as hemolytic transfusion reaction as acute hemolytic transfusion reaction or delayed hemolytic transfusion reaction. So recent transfusion and hemolytic transfusion reaction, it's the second type of the autoimmune hemolytic anemia. So if a patient presents with fever, flank pain, hemoglobinuria, renal failure, DIC within 1 hour of transfusion, so it's considered as acute. And if patient present in 2 to 10 days after transfusion, so it's considered as delayed. So in acute cases, stop the transfusion immediately and give supportive treatment like fluid and vasopressors, fresh frozen plasma and platelets if DIC develops, and hemodialysis if there is a hyperkalemia and ECG changes, repeat type and cross match. In delayed case, only supportive care is given. Now we should discuss the non-immune mediated hemolytic anemia, in which state is negative. So we can classify it as extrinsic defects and intrinsic defects. In extrinsic defects, the RBCs are destroyed in the spleen, hypersplenism, extravascular hemolysis due to infections like malaria. So we will find trophozoites, and in the BCI we can find Maltese grass. And due to toxin like lead, we can see basophilic crippling and Wilson disease. And also we can have mechanical destruction. So in mechanical we have microangiopathic and macroangiopathic. In microangiopathic we have valvular hemolysis like aortic stenosis, mechanical valves, and March hemoglobinuria. While in microangiopathic cases, we will have hemolysis along with thrombocytopenia. What are the classifications? So we have TTP, thrombotic thrombocytopenia, purpura, hemolytic uremic syndrome, DIC, and HELP, and other malignant hypertension, scleroderma, systemic malignancy, and complement mediated. These are all classification of microangiopathic hemolytic anemia. While in intrinsic defect, we can have enzyme defect, membrane defect, and hemoglobin defects. Enzyme defect, we have G6PD in which extravascular and intravascular both hemolysis can occur, and smear you will have bite cell and Hens bodies, while in pyruvate kinase extravascular hemolysis occur and you can see on smear echinocytes. Membrane defects, we have hereditary spherocytosis in which extravascular hemolysis occurs, and on smear we see spherocytes. While in PNH paroxysmal nocturnal hemoglobinuria, we have extravascular hemolysis. Then we have hemoglobinopathies like sickle cell disease, HBC, and thalassemia. And in sickle cell, we on smear we have sickle cells, and in this extravascular and intravascular both can occur. In HBC, we will have target cells on the smear, and thalassemia we will also have target cells.